All right, well, good afternoon, everyone. It is my pleasure to welcome you. That's from Cardiovascular Innovations Foundation. Today, a webcast regarding CTO interventions. And it is my pleasure to introduce an amazing faculty, amazing CTO operators and good friends, starting from Dr. Khaldun Alasfat from Detroit Henry Ford, then Dr. Arashi Maran from American University of South Carolina in Charleston. Then we'll go to Dr. Paul Pumipanit from University Hospitals in Cleveland, and then finish with Dr. Jason Walmuth from the Providence Cardiovascular Institute in Providence, Rhode Island. So all amazing operators and have excellent cases to share with us. So thank you guys for being here today. It's very exciting. I know you had a lot of Zoom share lately, but I'm very excited about this because it's pure cases and discussing the latest and greatest, and we'll learn from each other. Just for the audience, at the end, you can go to the link that can give you CME. This is a CME accredited event. And I would like to thank our sponsors for supporting this webcast, Boston Scientific and Medtronic. And without further ado, I'm going to pass it on to Dr. Kyle Alasfat, who is going to start with the first case.
All right. Good evening, everybody. I'm going to share my screen here and start. This is just a discussion about revascularization and revascularization strategies, and especially when you have CTO. And we have a great panelist here who is who of interventional cardiology and CTO operators. And hopefully over the next few minutes, we can actually bring to bear a few concepts and techniques that we will share with you. So I'm going to start with my disclosures. So it's basically a case presentation, 66 years old male. One of my colleagues called me, he said, well, this guy has positive stress test, has chest pain, angina, and he has a claudication. So I'm going to send him to you because you know how to handle both peripheral and coronary. And I didn't know there was other reason. He's a little bit tough patient. He 16 years ago received a penta stent, the RCA 2.5 by 18, and in the Circ 2.5 by 8. Still have positive stress test, and the EF is 66%. So I performed the angiogram, and this is basically what I found. He's a relatively young, but you can see the outline of the artery before you even inject, even before the motion of the heart, you can see the outline. The RCA has two branches, both are occluded in a large marginal branch. Another view of the RCA, the PD and posterolateral branch, early bifurcation. Those are the toughest CTOs when the RCA is early bifurcation. This is the LAD. And if you can tell here, it's filling the RCA, and this is the Circ. So the Circ is actually large in filling retrograde via collaterals, probably proximal significant lesion, then another lesion, then a third lesion, which is, I couldn't understand much. I thought it could be a channel there. So he has a severe claudication. So I did a picture with normal, and he has bilateral common femoral artery stenosis. Is very, very tight. For the sake of time, I did not show more pictures, but believe me, both common femoral artery are tight. So I actually sent the patient for surgery and to discuss with the referring cardiologist and the surgeons, and met with the surgeons. And it took quite a while. And the patient, the wife is a pharmacist, the patient an engineer, very well educated. They said no bypass surgery despite our best effort. So what would you do now? These are the questions. Treat the LAD and medical therapy for the residual coronary artery disease, which is something we used to do in the past. And still, I'm not put in the light of the ischemia trial now. Could be reasonable, I don't know. Medical therapy only. Also, he has 12% ischemia, if you remember, so that's kind of moderate, not really high risk. He does have symptoms, however, or complete revasc. So Manos, do you want to discuss this, or should I keep going?
No, I think it's a good idea to get maybe some opinion. I think, medical revascularization, this is a patient who is fairly young, looks like. and he's got two CTOs, right? LAD and circumflex. I'm sorry, circumflex and right coronary. The
Mhm.
LAD also might have a disease on the proximal. I think he does need revascularization. Now, I agree with you, surgery is probably the better option if he's willing to go for it, but if he's not, I would go for revascularization, and given his function, I'll go for complete. I don't know, Arasi or Paul, any other thoughts on this?
I think given the fact he has symptoms and that he has 12% ischemia, complete revascularization would be my choice. And if he's against surgery, then PCI would be the way to go. After fixing the peripherals, I guess.
Yeah, I think, you know, fixing the LAD is probably not the way to go. I mean, if we look at the data, what are we trying to get better for this guy? We're not going to improve his mortality. We're probably not going to decrease his risk of MI to a great degree. What we are trying to fix is his symptoms, and what's symptomatic in this guy. It's almost certainly his circumflex and his right, not the LAD. And so those really need to be the targets of intervention. You know, the LAD itself, you know, we didn't get a lot of pictures of it. I'm not even sure how significant it is, but you know, that could be something that could be evaluated with hemodynamic assessment with FFR or RFR, IFR. So I think you really need to target the right and the circ.
So there are multiple data sets, including 89,000 patient meta-analysis that showed if we achieve complete revascularization, we're actually similar outcome to bypass surgery. I have to remind everybody that bypass surgery in normal EF non-diabetics did not actually decrease mortality, even in patients with a 3-vessel disease. The left main is a different animal. So, but the outcome with stenting, if you want to offer the patient therapy, you should insist in sending them for bypass surgery unless you can offer complete revascularization with a stent. So basically, we brought him to the cath lab, and I actually did go from the groin. And this is the circ. I thought the circ has a channel, and I found out really fast that the circ does not have a channel. This is actually, there is a second, and the wire is completely in the subintimal space. So I hadn't thought and planned the procedure as a CTO, so I was able to pivot, and I think that's basically important. You see that the microcatheter there wouldn't even go. That calcium is what was so horrendous. I didn't even want to worry about it because I know even if I cross it, I still have to need to rotablate it. So I kind of pivoted and went to the LAD, and I did the orbital atherectomy of the LAD. There was hypotension when I activated the orbital atherectomy. Hypotension in the patient, even after orbital atherectomy. This is a cutting balloon, and then we did a 3.5 by 24 stent, and now I have completely different approach. And I don't know basically what you guys do, but I normally, if I have two CTOs, I normally go with the easiest first. And obviously the easiest here is the RCA because I already failed in the, in the circ, so that's no brainer. So I went and changed, reattempt left circumflex, still the patient, I am not touching arteries. Their arteries with temporal blood pressure scared the heck out of me, and changed the approach. So the question now, would you, when you bring them back, if you're planning on doing the RCA, would you do anything else? Would you do anything different? Remember, he became hypotensive during the rotablation, orbital atherectomy in the LAD. And if you remember, there are septals I might need to use to go down from the LAD to open the RCA. And RCA has distal capita bifurcation, early bifurcation, and a stent. So it's complex. Any comments, guys?
I think since you fixed the LAD already, I understand, you know, we are using multiple catheters. You should not have much of a problem, I would think. You have a patent stent now. Earlier, it was a diseased vessel, so, and RCA and circumflex territory were not revascularized. But now the LAD has a stent, so I'm not leaning towards hemodynamic support at this time, especially given his peripheral vascular disease, the way it is.
So I am a little bit more cautious than you, Rasi. So I actually did obtain access in the groin and took a picture of the subclavian, and it looks pristine. And I needed 2 guide catheter. The reason is I tried to put If he crashes and I have this peripheral artery disease in the middle of procedure, I will be really up a creek without paddles, trying to get axillary access. So I thought to myself, just in case I go retrograde and the LAD has still the disease, even like distal to the stent I put, there is still a disease. And if I go into RCA and I have ischemia, and then emergently to put hemodynamic support is going to be a problem. So you have to factor that.
Yeah, this situation comes up in patients that have, you know, bad AS or they have peripheral arterial disease, and you always have to think, what's your bailout option and how quick are you at getting it in? And you know, if a person has big femoral arteries and you've got good access, you know, you can get an Impella and get somebody on support, you know, in 2 or 3 minutes. But if you're talking about doing an axillary case or doing a shockwave facilitated iliac case, you know, those are not quick cases. Or if you have to do a BAV to get one in, that takes, you know, 20 minutes, 30 minutes sometimes. And you know, in a patient who has unstable hemodynamics, they may not have that time. So, you know, I kind of agree with Rossi in that I don't think that the patient's probably going to need support. But like Cal said, you know, you're planning for the worst, and when you've got time to get a support device in a patient with complicated PVD, it may not be an unreasonable thing to do upstream like you did.
Exactly, and this is what
I'll ask you quickly. How would you do? I know you do a lot of experience with transcaval in your place, and you know, here obviously you have a subclavian. When would you consider transcaval? It's only if you don't have subclavian. Do you ever go with the transcaval even if you have subclavian, or you always go subclavian first?
No, I go with subclavian first, but if I'm planning on leaving the device in, or I want to use 5.0, I'll go transcaval.
Okay.
So this is the RCA, and we have like basically, you can tell the RCA has early bifurcation, PDA and posterolateral branch, and I'm going to try and integrate, and there is a stent in the situation there. We tried antegrade and we failed immediately. There is no good target for ADR. So here we are trying to go retrograde through the septal collaterals. So what happened, I want to take you back a couple of slides. So this is what I did. I did the axillary, and I took Jason Wilmuth technique, and I put 7 French sheath inside it. It was ergodynamically, to me, it was very hard. It was very hard to manipulate the guide catheter and be comfortable for the left main. I put that for the retrograde guide. So I basically, instead of struggling for the rest of the case, and I know this is going to be long, I switched immediately to a groin. I obtain access in patients who have calcification. I obtain access under fluoroscopy, don't have to do with a micropuncture. We did a tip injection, and here the retrograde wire right at the distal part of the penta stent, that old stent in the RCA, 16 years old, and trying to basically advance the caravel. Nothing will go other than the caravel. So the caravel made it finally retrograde when we crossed through actually the barrel of the stent, and this is a reverse card. Now I could not advance the caravel anymore. So what I did, I kind of trapped the retrograde wire here with 4mm balloon, and that gave me a rail to advance the caravel retrograde. And finally we got through. So now I have the PDA, but I don't have the posterolateral branch. So what we did for the posterolateral branch, we basically did a subintimal plaque modification. I just knuckled star technique and I ballooned it. And I thought to myself, when I bring him back for the circ, I'm gonna look at it and see if I fix it. So the patient, by the way, at this stage became asymptomatic. I would not stop because, as I said at the beginning of the talk, if you're gonna perform revascularization, similar to CABG, you have basically to perform complete revascularization. And this is probably was the first MANTA case in the US to close axillary artery or subclavian. So we use a MANTA device for closure. That actually, this is number 3. And we had to tap it. We had to balloon tamponade it for a while, and results were perfect. So when we came for the circ, so here I kind of tried again. I put the wire in, but this time I became better prepared. So what I did, I advanced the balloon in the side branch. I want to crush the proximal cab, and I'm gonna try to see. And if you look, the circ, a distal cab at a bifurcation, heavily calcified. Even if I go antegrade, I would basically end up in outside calcification. It's very difficult to re-enter in these situations. So we did a tip injection with a Carvel catheter, and this is kind of collaterals, epicardial collaterals. Another more distal tip injection, you can see another tip injection. And this is actually Suho wire, which went really easily across, and we crossed it in no time. I want you to notice this here, this here. This is when you push and tug with the wire, they basically evulsed. However, I did not panic. I know evulsed in the, because most of the time those evulsed in the LV. I did not panic much. And now we're trying to push a knuckle retrograde to kind of meet with the antegrade gear. So we went, we kind of dilated. This is here. We try, after we performed reverse cart, the wire is trying to get back. And if you notice here, the wire is flying. I used Xi'an, regular Xi'an, and the wire went out. So now this is a 24 atmospheres balloon. Do you guys see how much calcification? So what would you do here? I could not dilate this. 24 atmospheres, I was able to deliver the balloon, but if I keep pushing here, I'm worried about perforation. So any thoughts, ideas?
Externalized, Carl? You're externalized at this point?
Yes, externalized.
So some people have done a rotablation through an RG3 externalized, which again is not approved technically speaking, but might be one way to do it. Another way is just get the rota wire and do a atherectomy. But I think for something like this, you're probably going to need to do a atherectomy, otherwise probably won't expand.
Absolutely. So I stopped using RG3 for rotablation because Yamane, Sensei Yamane told me one time they had the wire separate, and basically it fatigues very easy. So if you have long run, you could actually kind of separate the wire, and you end up with a massive perforation. And that's what happened with them, our Japanese colleagues. So what I did, basically I externalized the rota wire. So I got back in here and I externalized the rota wire. And when you externalize the rota wire, you externalize the tip. So you cut it, you cut the tip, and you thread the rota over it. And you don't see the back of the rota. The wire is not long enough. It's only 325, so you have both ends of the wire. So this is 1.5 burr going in. And if you notice here, kind of we are dynagliding all the way down. We rotablated it, and now it's expanded really nicely with the balloon. Now, when you remove something like this, I know in the back of my mind it's evulsed. I actually maintain access. So if you notice here, there are 1 microcatheter in the antegrade, 1 microcatheter in the retrograde. So this is here, I do like the microcatheter kissed and I remove them. And look here. Do you see what we found? Significant bleeding into the left ventricle. Good angioplasty results. So what would you guys do for this? This is inside the left ventricle. Would you leave it? Would you do something about it? Any thoughts?
I think the first thing you're going to want to do is get an echo and just confirm that there's no obviously leaking into the pericardium. And a good way to do it is to inject DEFINITY into the coronaries and look to see what lights up first. And if you inject into the coronary and the first thing you see is some bubbles showing up in the left ventricle, then you know it's just going into the left ventricle. You can always obviously see if there's any draining into the pericardium. But if the first thing you see is draining into the right atrium, then you know that it's probably not going anywhere significant, or there's no significant perforation. Obviously, you can see a perforation here But I think just making sure that there's no bleeding into the pericardium would be paramount, because you don't want to give up your wire access and your microcatheter access in case you need to drop coils or fat or thrombin or something else.
Would you drop a coil in this, or thrombin, or
Absolutely not thrombin in this case, because
Okay.
if it's going into the LV and you put thrombin in there, that will go into the LV as well, and you've got thrombus in the LV, and you know, that could be a disaster. If you had to do something, I would do probably a coil.
Yeah, I agree. It's going to be coils or nothing. You know, fat or thrombin, even if it's going in the LV, is going to go out systemically, and your patient's going to end up with something really bad. So
do you have to coil both ends to stop it, right? You have to coil both ends.
Epicardiocollaterals obviously bleed from both sides, and so you would need to coil both ends. And that's the importance of, you know, maintaining wire position and maintaining your microcatheters, both antegrade and retrograde. That way, if you do have a problem in your epicardial collateral, you've maintained control by having a microcatheter at either end, and you can drop in an 014 coil through the microcatheter that you use for the interventions.
So
Now,
here,
how is the patient doing hemodynamically at this time?
stable like a rock.
So if he's stable like a rock, I have been kind of, and if the echo does not show an obvious pericardial effusion, I would take my gear out and give him protamine and see what it is before coiling any of this.
You're right. Actually, you could have done that. I wasn't 100% sure. There was, if you look at the cardiac silhouette here, I want you to notice, this is one other clue. Normally, if there are pericardial effusion, you can see it. You can see like there is a double edge of the cardiac silhouette. So coils, if I have to do a coils, I'm going to have to coil a branch like this one here and this collateral. So I chose something different. I chose to basically put a covered stent. I have the PK papyrus. I put a covered stent in here, and I thought I'm going to coil the other end. But I have to just to pull the microcatheter. So I'm trying to figure out where it is, and I'm injecting. So basically, we wired it. I had to stent proximal segment, finish it off, and then wired, finished the left main, the patient stable, and then basically finished wiring. This is a covered stent, papyrus. This is after I'm trying to figure out where to deploy it. So when I put it through, it closed it, so I couldn't see it. So now here, deployed it, and this is the picture after the papyrus. So I don't see anything. All the perforation coming from one end. So I did not need to put a coil from the other end. So let me just play it here. So the papyrus is here, and there is nothing bleeding from anywhere else. So I just left it. And this is basically was our outcome. So again, this is comparison of stenting versus bypass surgery, 3 major surgical trials versus stent, syntax, pre-combat, and best trials. These are meta-analysis. They actually looked at the patient, the outcome with complete revascularization versus partial revascularization with each modality. And if you achieve with the stenting, even in the syntax above 32 here, PCI, complete revascularization, was similar to the surgery. The red, solid red, and solid blue were identical. Even in diabetics, the red solid and the red blue surgery versus PCI were actually not statistically significantly different. So my advocating here that if you want to treat a patient surgical turn down, you really have to provide complete revascularization. Patient no angina. I treated his legs as well. He has complete revascularization. He actually, the posterolateral branch shut down again. Now there are collaterals to it, but the patient is completely asymptomatic. And if you remember, those branches do not go to a large area of myocardium. So I left that branch alone. And a patient agrees to that. These are some of the data, some of the books you can go to if you want to expand more on this. Thank you so much.
Thank you, Carl. That was a phenomenal case, super challenging with a lot of things going on. So thank you so much for showing that. And then we'll go to Dr. Maran, Rasi Maran, who will show another case. We cannot hear. I think you're muted, Rashi. I'm sorry. I think you're still muted.
All right.
Sorry.
So let me start again. So my patient is a 71-year-old male with known coronary artery disease, status post CABG. Lima to LAD was patent, vein graft to an OM, which backfills a large bifurcating ramus. He also has a full metal jacket of the right coronary artery, which has multiple layers of underexpanded stents, and he keeps coming back with recurrent angina. And here this is the right coronary artery. And as you can see, it's just diffusely diseased, multiple layers. And at the time of initial presentation, we just did laser and balloon angioplasty. I won't go into that detail. This is the left main stump, which we were going after. As you can see, it's a beautiful vein graft, backfilling and circ-OM, and then through a severe distal disease, fills of ramus superior and inferior branch. And this was our target. So we decided to start, and this is the balloon angioplasty result after the laser. And we were not that successful. As you can see, there's still, there's so much calcium behind, and there are 2 layers of stent. But he was a little better. We decided we are going to proceed with the left main PCI, just so we revascularize him to the best of our abilities, given knowing that this RCA is going to be a problem continuously. So proceeded for CTO PCI of the left main stump. The JCTO score, I mean, looking at the angiogram, seems very simple. There's only calcification. And even with the progress CTO score, there's just calcification. The length is less than 20 millimeters. So we thought, okay, bifemoral axis, this is going to be a fairly simple case. Should not take us a long time. So start with a microcatheter and a wire escalation with a Fielder XT and a Pilot 200. We could not get any traction at all. Every time we gave any forward push, everything would get kicked out. The microcatheter would not even get buried within the proximal cap. So we decided, let's do scratch and go. And I usually start with the Gaia 2 and then go to a Confianza Pro 12 and then an Astaro 20. But as you can see, it just kicks out everything, and tried just tabbing it with the Gaia 2 and the Confianza Pro 12, then went back, de-escalated to a Fielder and a Pilot 200. So it's this lesion is clearly not following the scores as I thought it would. So now I decided I have a beautiful vein graft, comes all the way to the distal cap. Let me use that as a marker and try the same. And that was not working either. Now, somehow I got a wire, Pilot 200 in the subintimal plane. I could see the wire literally wrap around the left main and kind of be in the subintimal plane. And I thought, okay, if I get the wire far enough, maybe I can get the microcatheter down and then switch it out for something else, and maybe a laser again, or rotational atherectomy or something. But I could not get my microcatheter in antegrade at all. Then I thought, okay, let me try reverse cart, then maybe get a twin pass torque and then try to get into the ramus. And I could not get any balloon to do reverse cart. Multiple attempts, everything was failing at this point.
Maybe we can check. I mean, Paul or Jason, any thoughts here? I mean, this is a fairly challenging lesion, much more challenging than we thought initially. Any thoughts about what you do next?
I've actually done a case like this before, where it looks like your interventional fellow should be able to wire it pretty easily, and you just can't do it. So basically, and I had to do a second attempt when I did it. So I basically, the first time I was radiofemoral, got almost nowhere. I got a wire into the left main, but it didn't go any farther. So I brought him back. I cut a guide. I put an 8 French inside a 6 French multi-purpose, and then I put a guide extension inside the 6 French. Went all the way down the vein graft and up the native. And that gave me enough push to get whatever the heck I wanted, retrograde, and basically did it that way. So I ended up using, I think, an Astaro 20 to poke into the aorta. And it's just a matter of snaring it and doing what you need it to do. So that's how I solved that problem in a case similar to this.
That's a great solution, because obviously one of the challenges going retrograde down a vein graft when you get to the lesion retrograde is you oftentimes don't have a lot of support to push. And so the usual solution is just taking a guide extender as far down the vein graft as you can. It's a case where I like to sometimes use the longer guidezillas that are made for radial, because you can get them all the way retrograde into the circ, and that sometimes will give you enough body to push. But I also think this may be one of those cases where, you know, you've got a very short segment that you're trying to get through, and you can't get through retrograde, and antegrade potentially is going to get you in the wrong subintimal plane and potentially lose either the ramus or the left the LAD. And so this may be a case where you really want to go retrograde because your distal cap's at the bifurcation, and this may be a good time to consider E-cart.
All right.
Horacio, what do you guys do?
So at this time, I mean, reverse cart did not work, and I haven't done an E-cart. I've heard about it, I've seen it, but I haven't done it. So I decided, let me try cart. Let me just get a balloon retrograde and kind of modify the plaque through the vein graft and see if that works. So I used a 2.5 balloon, a 3.0 balloon, and that also did not work. So I was really stuck here. And I thought about, I have, you know, done laser atherectomy with the wire in the subintimal plane distally, but this was in the left main, and I really did not know how superficial or where I was, and I didn't want to take a laser and poke a hole through a left main stump in the subintimal plane, nor was I comfortable doing rota at this time, knowing that my pilot 200 was in the subintimal plane of the ramus. And then I took a picture just to see what I'm doing, and I'm causing so much hematoma with the circumflex. Now I started beginning to lose flow in the ramus branch. So at this time I said, okay, I have modified this plaque to the best of my ability right now without doing a cart. Let me bring the patient back in 6 weeks, allow for plaque remodification, remodeling to happen, and then be prepared for E-cart at that time if I need to go, and go from there. So that's what we did, brought him back in 6 weeks. Flow to the ramus was restored, the proximal cap was unchanged as suspected. And so lessons learned from the previous time went quickly retrograde and came back in with a Corsair and a Pilot 200. And this time I was able to directly wire the Pilot 200 into the ramus. And took away the opportunity for me to do the E-cart, but as the wire got into the true lumen. The rest was just IVUS guided PCI. And before that, given the difficulty I had the last time, I know my wire is in the distal true lumen. I was able to do a rotational atherectomy that was a 1-2-5 bird. It took a little hiccup, but it went well afterwards, polished very easily after that. And this was my flow after that. I don't know whether you can make out, there's a small little perforation or a little staining there. Patient was hemodynamically stable at this time, so I was like, let me see how he behaves. And we just proceeded with PCI.
Beautiful.
And we did the left main into the superior branch of the ramus with the Y stenting strategy. And this was my final result. You can see a little perforation here. Patient was hemodynamically stable. And I basically let hemodynamics define what my next step should be. I got an echocardiogram. He didn't have any effusion at this time. So I took out all my gear, gave protamine, and he did fine. Would anybody else done something else with the perforation?
No, post-cabbage perforations on the surface of the left ventricle usually are hemodynamically stable and don't lead to major issues. And so I think your strategy of, obviously you want to get an echocardiogram, you want to see how the patient's doing symptomatically and hemodynamically, but the vast majority of the time you can just give protamine and watch those, and they heal on their own and they don't lead to any clinical significance.
So, Arasi, did you do the E-cart with the antegrade guide? Or
oh, no, I didn't. I said he took away the opportunity because I directly wired it with the Pilot 200.
Oh, you directly wire the antegrade.
Antegrade, yes.
I think this is a great case, though. It shows, you know, the value of an investment procedure. You know, you learn about the anatomy, you learn which guides work best for you. You change the plaque by doing subintimal plaque modification like you did. And you know, it's okay to fail, but fail with style. Do something different to that artery that's going to change the architecture, change the anatomy, and change your thinking and your approach, so that the next time you come around, you're going to have a much greater likelihood of success. And I think that this is a great case of that.
I think that exactly was my point. I realized that proximal cap was so difficult, and if I couldn't wire it, I think I just got lucky wiring it. I was prepared for E-cart. So that was what, I mean, since it was my first time doing it, I wanted to come prepared, and I just did not want to do it ad hoc. But thankfully, I guess, or not, the wire went, the antegrade wire went easily. And so this was our result after 3 months. It still looks beautiful. So my lessons is, you know, the scoring systems sometimes does not predict the complexity of the case. And I think you just have to be prepared for all, have all your contingency plans. And safety first. I could have, you know, pushed myself and done laser, or I was not comfortable trying E-cart ad hoc. I wanted to come prepared for it, and I did not want to do it just like that. And I always believe plaque modification works, and as long as I've done something to the blood vessel, when I come back the next time, it's never failed me. And reverse cart did not work for me. I mean, so I went and jumped on cart, and that's what saved the case for the second time around.
One word of caution, when we do reverse cart or cart in the left main like this, you just have to make sure that there is no dissection left and intact, because the left main could dissect and it could spiral up, and you don't actually see a cusp dissection. You just see, when you pay attention, you're going to see just the whole aortic root dissected. In a few patients, that could happen. Obviously, there is some kind of genetic predisposition to it, but we have to be careful with atherectomy in the left main when you do reverse cart or cart. It's very, very important to kind of be very meticulous. And I don't think I will use orbital atherectomy if I've done reverse cart or cart. So rotational atherectomy is the way to go.
It's a valid point. In general, I mean, for all my CTO cases, just because, you know, your wire could be going in and out of subintimal planes, I always choose rotational atherectomy, and I always choose a smaller burr unless I'm absolutely sure, like a 125 burr. And after the burring and irising and making sure where I am, then maybe if I need to, a 1.5 burr. I don't choose orbital atherectomy for the same reason you mentioned too.
Perfect. Well, again, that was a phenomenal case. Thanks again so much. I think in the interest of time, we should go next to Paul Pomipane. And again, thanks, Haraj. That was a great case. I think different lessons, different challenges, but I think that's both cases so far, so that CTO remains the last frontier, and we're excited to see the next couple of cases.
Is there any questions from the audience, or this is not audience questions either?
That's a good point, actually. There is one question that came about: how do you resolve ambiguous ostial RCA in the proximal cap when going retrograde from the LAD? If you can't access the proximal RCA, and I think, Caleb, you want to take this since you are the most experienced in E-cart and reverse cart. So you have ambiguity on the ostial RCA, essentially flash RCA CTO, and you go retrograde. How do you know where to poke?
So it's very important to kind of really be deliberate in this. And sometimes if you cannot figure out where to poke and you have a flush RCA occlusion, don't feel shy of stopping and getting a CT. Get a CT, but talk to the radiologist. You need actually different phase to see all the way where the RCA, trying to figure out where the RCA is. Even review the TEE or the echo. Sometimes that actually can tell you where the RCA is. So this is obviously flash occlusion. You go back with the retrograde. The only solution is retrograde. And I will use a JR4 guide catheter in those patients, 8 French JR4 guide catheter, and I will push the knuckle, and I will make like multiple attempts in trying to figure out where is the calcium that actually attaches to the proximal RCA. Multiple views, multiple cines. It's not the time to save an end radiation. And I'll push the knuckle, but I would not allow the knuckle basically to exit up into, because the knuckle, if you push it, is going to actually go up in the aortic root. And you need to get the microcatheter as close as possible to the tip of that knuckle. And then you're going to have to verify with your JR4 guide catheter with a very good pokey wire. And I will use very directional wire, like a Gaia 3rd or Gaia Next or Confianza Pro 12, even Astado, and a microcatheter. And you're going to see, you put it and you take multiple views. You see if they are dancing together, and you take multiple views. Very important to take audio and LAO to see that you are actually overlapped in all these views. And then you can either poke toward your retrograde gear, which is probably theoretically safer, or poke back. I prefer to poke antegrade because a lot of times the RCA, when you poke from the inside the vessel toward the aorta, a lot of times you don't really, like you're not seeing the coaxiality. So the minute, if you poke antegrade and you can get about 5 millimeters with the tip of your microcatheter, I will switch immediately to the polymer jacketed wire trying to knuckle it. If you want to use reverse E-cart, you have to use a catheter that doesn't melt. I will change to fine cross, and I will basically take a swab. I put a snare in the aortic root, and I basically take a swab and go. Very important, don't follow it with a microcatheter until you make sure it's interacting with your snare. Then you can actually now get it out and get your microcatheter out.
Perfect. Thank you so much. And again, for the audience, Dr. Olivan just published the largest series of e-card on JIC. So feel free to read it. It gives a lot of instructions how to use it with inspired. So thanks, Carl. That was excellent point. Okay, now again, Dr. Pumipanen is going to discuss the next case.
All right. Good evening, everybody. Thank you for having me. I'm going to go pretty fast because it's like everybody else's case ends up being a pretty long case. So this is a 64-year-old patient. He has a remote history of LAD and circumflex artery stenting. He underwent 3-vessel bypass surgery in about 2005. He underwent drug-eluting stenting to the native right in 2011 to perfuse a posterior lateral branch. He underwent drug-eluting stenting to vein graft to the OM in 2013. And he's pretty much not had any heart catheterization since that time. He has class 2 to 3 angina. He had a stress echo, which demonstrated preserved EF with ischemia on the lateral wall. And this is his diagnostic cath done in a different sitting. So you can see the left main is pretty much occluded. It leads to a stump in the proximal circ. The LAD is pretty much occluded in a previously placed stent. He has got a vein graft. Let's see if I can play that again. He's got a vein graft to the posterior descending artery that perfuses the PDA and then retrogradely fills the left posterior lateral branch as well as the right posterior lateral branch. He's got an occluded vein graft to the OM, and then he's got a patent lima to the LAD, which backfills a diagonal, which fills a very large first obtuse marginal artery, which is where that previous vein graft goes to. So I talked to him about this, and given the enormity of disease, I usually tell patients 3 hours or less. I told this guy 4 hours or more to get this one taken care of. I started with bifemoral access. I had a diagnostic catheter in the internal mammary artery. I had an AL1 in the vein graft. I tried a Mongo and a Pilot 200, and it just kind of laughed at me. So I ended up having to use a Pro 12 to get across the stent, switched back out to a jacketed wire, and had a knuckle Mongo to get it into the mids graft. And then took a Pilot 200 back again and just wired true lumen into that OM that you can see on the right panel. The issue here was trying to make that turn back into the proximal OM. It took me a little while. I almost put a supercross down there, but I was really hoping not to have to switch out for something else. Eventually, I got a wire to get around that bend, and I was able to deliver. This is a Corsair Pro XS. But when I tried to put a jacketed wire up there to knuckle it, it just kept going into some small branch. So I ended up doing a tip injection on the left panel. And I was basically trying to hydraulically dissect this vessel so I can get a knuckle up there. I ended up having to use a Pro 12 to get to kind of poke, and then got a jacketed wire and got a Mongo to knuckle to that stent that's in that circ. And this is where the interesting stuff happens. So then I ended up pulling my diagnostic catheter from the Lima, put an EBU4 into the left main. Once again, tried jacketed wires to get through the proximal circ, and it just laughed at me. Even a Gaia third would not go through there. I ended up having to use a Pro 12 to get down there, and it just went right into that circ. So I ended up having to do this twice because I lost wire position. So I checked in a couple views to make sure that they were crossing. And then I got antegrade gear down there, then tried to do reverse cart. And I tried 3 or 4 different wires and just could not get it to make a connection in the circ. So this panel on the right was this panel on the left was me actually giving up and trying to knuckle into the left main so I could do reverse cart more proximally. And you know, the jacketed wire just flew into the antegrade guide extension.
Was it the Mongo wire?
That was a Mongo, yeah, actually.
Yeah,
And I didn't cuss. I was very happy that this happened, but at the same time, I just said it figures, right? Right when I'm about to give up on doing something, that's when things work. So, so externalized the wire into the circ. And then I ended up actually going after the rest of the AV groove circ. I think a lot of people would probably say, you know what, I'm going to get that huge OM. It's going to be great. But I think to completely revascularize this guy as much as possible, I felt the need to go after this AV groove circ. So I got a third access in the radial artery. I put a diagnostic catheter into that vein graft. I didn't think there were any retrograde options, going up a PDA, then down a right posterior lateral branch, then into the circumflex system. So externalized wire in the first OM into the circ. This is a Sasuke microcatheter that is in the circ itself. I ended up knuckling another Mongo to the distal cap, or where I thought the distal cap was. Got a microcatheter down there, and then this is a Stingray balloon. I tried stick and drive, even though it's a really small vessel, and it just landed me in one branch after another. At this point in time, the patient started trying to get off the table because I'd had him on the table for a while. So I took another Mongo. I just knuckled down there, hoping I could star into the vessel, and lo and behold, you know, on the right panel, you could see that the wire was actually in true lumen in the AV groove circ. So I took what I could get. And so going back, I ballooned it appropriately, did kissing balloons. I put 1 stent into the AV groove circ. And you know, this is where operator fatigue kind of comes in. So I didn't actually put a second balloon in that first OM. So I ended up having to take a microcatheter and cross that stent to be able to get a balloon down there, which was 15 minutes of my life I'm not getting back. After that, it ballooned the OM to the circ, stented left main, recrossed, ballooned everything, kissed. And I ballooned, so the 16 atmospheres with this kissing balloon. I took a 3.0 there, and I went to 30 atmospheres, and I took a 3.5 and went to 22. Left main, I went 4.5 to about 16 atmospheres. I ended up coiling that vein graft. And this was the final result. I was a little disappointed I didn't get that other branch that I really wanted to get. I thought it was going to stay. I thought it was going to be open, but that was a result. His result, actually. He did well overnight. He left the next day. 3 months later, he's completely symptom free. So.
Paul, question,
Phenomenal.
why did you have to coil the SVG? Was it like, did you establish flow in it? That's why?
Yeah, so I took a picture before this one where I thought I was really done and there was competitive flow. You can still see a little bit of it right next to those two staples.
Yeah.
You can see some competitive flow down the graft. So I knew I had to coil that.
Mm-hmm. Excellent work. Very, very good.
Yeah, it's excellent work. I think part of it is, as you say, we had to complete revascularization, and here you did get the vast majority of it. But I guess at some point, you're right. I mean, at this point, I don't think it's a good idea to try for the other brands. I mean, you've done so much good work already. I'm not saying you need to get everything. So this is phenomenal.
this one took 5 hours. I think if I had more time, I would have tried to go after that branch and put the Suzuki, which was already on the table, down there and tried to wire it. But I thought it was just going to be too much for him. So, there is a time that you kind of have to stop because the patient's telling you need to stop. So.
And I think you also make a good point of operator fatigue, right? At some point, if you get too tired, you start missing steps or forgetting things. And then actually it's a risk as well for you and the patient. So that's a great point to understand where your limits are and try to scale it back.
I actually consent the patient for multiple procedures in the dominant circ. So the circ, so the RCA is one vessel with two branches. That's all what you have to care about. And most of the time, you get them both. The circ is a small vessel with a lot of branches. So the problem, you can't win with the dominant circ. If to get all the branches, you have to count it as two vessels. It's need two procedures. I start actually consenting my patient on that basis because you get an OM and then it's going to be another CTO to get the second OM or the posterolateral branch on the PDA and the left PDA. So those dominant circ, I start kind of treat them as two vessels.
So honestly, I do the same too. All the time, I consent my patients for, I say 85 to 90% one procedure, but there's a small chance you may need a second procedure. And that kind of prepares them so that they're not surprised or shocked or disappointed with you. And that strategy has worked for me so far.
All right, perfect. Well, I guess in the interest of time, maybe we'll go to, again, Dr. Walmuth, so Jason. Sorry, you're the last one. I see your name that's with a W, but again, last but not least, we're very excited to see your case. Thank you so much, Paul, again, for a phenomenal demonstration.
All right. Well, thanks to everybody on the panel. This has been a lot of fun. It's always fun to see how other operators think and approach things, in the middle of cases. And, I think we're kind of staying on the theme today. This is a circumflex, and I tried to pick a case that I thought was going to stand out, but apparently it didn't. Apparently we were all thinking circumflexes, and after seeing these last three cases, you'll look at this and probably think this is a fairly straightforward case. But there's a couple teaching points that I wanted to kind of touch base on, and then lastly, I've got a kind of a clinical dilemma of how people manage this, and I'm really curious to see how other docs on the panel deal with this situation. So here are my disclosures. This is a case of a 75-year-old who was referred to me for PCI, kind of the usual past medical history that we see in these patients. Had a prior 5-vessel CABG in 2005. He'd been having about 6 months of exertional chest pain, tachycardia and fatigue, cardiovascular class 2 symptoms. And his symptoms were similar to what he had prior to his CABG. He was initiated on medical therapy. He was on relatively high doses of beta blockers and calcium channel blockers, but was still finding that he had to use sublingual nitroglycerin before he'd do physical activity to try to minimize his symptoms. So he ended up getting an echo stress test, and his Duke treadmill score was fairly marked with -19 score. He had anterolateral hypokinesis on the stress test, and you can see on the image on the right, his anterior wall was a little bit hypokinetic there. His EF, though, was well preserved, and so he was referred for diagnostic angiography, and this was done by one of my partners. Here you can see he's got patent right coronary artery. He's kind of a codominant right coronary artery, and he's got a graft that was very small, but patent to the PDA. Here's a picture of his lima to the LAD, which again was in good shape. And you can see at the very end of that IMA shot, some collateral spilling what appears to be an OM on the lateral wall. Here on the left main shot, you can see that his circ is patent all the way down to the distal vessel, but you don't see any obtuse marginal branches. There are a couple small diagonal branches that are patent prior to the LAD being subtotally occluded. On the left coronary shot here, you can see that there's a fairly high-grade left main bifurcation stenosis as well. And then you can see some collateral filling, left-to-left collateral off of that first diagonal branch, filling an obtuse marginal branch. And so after getting this, you know, I didn't show this, but all three vein grafts were occluded. My plan was to do an IVUS-guided left main bifurcation PCI to improve flow into the diagonal branches, and then to plan on fixing the OM CTO. Now, the OM CTO had some challenges. It was an osteal occlusion, and I had no idea where the vessel was, where it originated off of the AV groove circumflex, and obviously had an ambiguous cap. And so my plan was to fix the left main and then to do an IVUS-guided entry into the to the OM and consider either antegrade wire escalation or ADR. And if that wasn't possible, do a retrograde via the epicardial. That looked like it was a reasonable epicardial to use retrograde off that diagonal branch. So at the intervention, we did dual angiography. I initially put a 6 French in the right femoral artery to go up to the IMA, and then a 7 French right radial with an EBU guide. And then with dual angiography, we could actually see that there were 2 obtuse marginal branches, and I couldn't tell the proximal cap of either of these. The OM1 was filling off of the diagonal branch, which is what we had planned on fixing. But then I could see now, when I had dual angiography, that the other OM that was filling off of the lima to the LAD was actually a separate OM and not the same OM that I initially thought it was. And so at this point, we went ahead and fixed the left main, just did a DK crush bifurcation PCI there, IVUS-guided, fairly straightforward intervention. And if this plays here, we'll show you. Got a reasonably good result on that. We then used the IVUS to see if we could identify the cap of the OM, but because of diffuse disease and calcification in the AV groove circumflex, I couldn't see the cap. And so again, kind of just reviewing, you know, the approach for the CTO. This obviously shows the hybrid algorithm. This is a case where you have an ambiguous cap and a cap that I couldn't find with IVUS. And so because of that, this almost necessitates a retrograde approach. And so the 4 things that we want to look at with the angiogram to kind of determine which option and how to approach the vessel. One is the proximal cap anatomy. Is it defined or is it ambiguous? Is there a decent target for reentry? And if there is, then that potentially favors an antegrade approach. Are there usable collaterals or not? And those first 3 things are going to help us define which direction we're going to approach the CTO at. And then finally, the occlusion length. If this is longer than 20 millimeters, the chances of doing antegrade wire escalation are significantly less. And so just talking briefly about osteal CTOs, I know we talked about that just briefly when Cal was talking about how to manage an osteal flush occluded right. But this is something obviously that we see fairly frequently. This is a paper that was published several years ago and found that osteal CTOs were present in about 17% of CTOs, with about half being aorto-osteal and about half being side branch osteal occlusions. The majority of these are treated with retrograde approaches, and the success rates are similar to non-osteal lesions. But osteal CTOs tend to be longer CTOs, tend to have proximal cap ambiguity, tend to be more calcified, more likely to be seen in a patient with prior CABG, and more likely to have interventional collaterals. So here's a case of how to manage an osteal occluded vessel going antegrade. Again, oftentimes these are best treated retrograde, but if you don't have a good retrograde option, there are options to treat these in an antegrade manner. So this is a case of a diagonal branch CTO where you could clearly see the ostium of the side branch on IVUS, and we were able to use an IVUS-guided cap puncture using a penetrating wire. In this case, I think this is a Confianza Pro 12, and we were able to puncture into the side branch and then clearly see on the IVUS that our puncture wire was in the architecture of the vessel. So that's a good way to kind of manage a flush occluded or an osteo-occluded side branch vessel if there aren't great retrograde options. Here's another case where we tried to do the same thing. This was a high OM CTO, but again, there was a lot of calcification in the AV groove circumflex that prohibited us from truly seeing the side branch. But what we were able to do is take a wire and get it knuckling retrograde, and we could then see the wire on IVUS, which then gave us a target to poke antegrade. So in this case, the IVUS actually looked a lot like the one that you see here, where it was not clear where the ostium of the side branch came off. And so at this point, I knew I needed to go retrograde. So again, we're talking a little bit about retrograde or epicardial collaterals. Really, this is something that probably should be done by operators who have experience in retrograde PCI and having had experience doing retrograde cases either through old vein grafts or through septals that are a little bit safer, lower risk of complications. Epicardial collaterals tend to be more tortuous with lower success rates than non-epicardial collaterals. And the 4 predictors of success are the size of the collateral, the degree of tortuosity, whether there's side branches in the tortuosity, and the exit location of the epicardial collateral. Wire choice is a little bit different than what we would use for septals or for vein grafts. Generally, we only use Xi'an or Suo wires, and we try to avoid jacketed wires. Typically, I use a 150 centimeter low profile microcatheter. This is a case where I like the Turnpike LP or the Corsair XS as a microcatheter of choice, occasionally needing to use something like a Caravel. Epicardial collaterals are a little bit higher risk, like we said, than septals or vein grafts. And the choice of using an epicardial collateral oftentimes has to do with what you think the risk is in doing it. Perforation into an intact pericardium can obviously result in uncontrolled bleeding and rapid tamponade. In a post-CABG patient, I really have I have less reservation in using epicardial collaterals if they're not in the AV groove, because again, if it's on the surface of the LV on a post-CABG patient, these oftentimes are not clinically significant. Whereas in the AV groove, these oftentimes lead to very, very catastrophic complications if you perforate them, because you can essentially get a localized tamponade that can occlude either the left atrium or right atrium, and they can't be reached at with a pericardiocentesis needle. So I try to avoid those. The main mechanism for perforation of epicardial collaterals is avulsion, like we saw in Cal's beautiful case from earlier. And again, these oftentimes bleed from both sides. So when you need to control them, you need to control them from both the antegrade and the retrograde limb. So this is the case that we did. Again, we had a fairly visible channel. It was fairly straight. There wasn't a marked amount of tortuosity. And we were able to very quickly wire retrograde down the diagonal branch through the epicardial and back up the obtuse marginal branch with I think this was a Xi'an wire. We then spun I think this was a Turnpike LP catheter. We spun that back through the collateral. You could see our wire was tending to want to go up the old bypass graft. You can see the tent from the old bypass graft, but eventually we were able to get our microcatheter around that. And then we were able to use, I think I went with just a Gladius wire, planning on just pushing it up towards the proximal cap, and it actually went true to true retrograde and out into the aorta. So at this point, we were in pretty good shape. I spun the microcatheter all the way around, but couldn't get the microcatheter to go out the left main. But you can see on the left-sided screen, I had my wire sitting about halfway up into the aorta. And at this point, I went ahead and switched out for an R350 and snared snared the wire. After we snared the wire and externalized it, I passed a microcatheter over the externalized portion of the wire with the plan of going ahead and switching out to an antegrade system. Whenever I'm working at a bifurcation, like I would be on this case, because I'd be at the Circ OM bifurcation, I find it a lot easier to do that with 2 antegrade wires than one externalized wire. Just gives you more freedom as far as your bifurcation stenting options. When I did this, I tried to pass the microcatheter over the externalized wire, and the antegrade microcatheter would not go through the left main stent. So at that point, I knew the reason I couldn't get my retrograde microcatheter out of the left main is that I had gone under a stent strut in the left main stent that I just placed. And so at that point, I took my other guide, my antegrade guide, I pulled my retrograde or my externalized wire out, was able to wire down the AV groove circumflex, used a balloon to deliver a guide extender into the proximal circumflex, and then we were able to easily wire back retrograde into our antegrade microcatheter. So again, using a ping pong technique. And at this point, then I was able to switch out to an antegrade system. Again, you can see that I maintained wire and microcatheter access in the diagonal branch, just in case there were any issues. Did a balloon inflation with a 1.5 balloon to restore flow, and then did stenting of the OM all the way back up to the proximal circumflex. Ended up having a little bit of pinching in the AV groove circumflex, so did just a balloon kiss there. I did not stent beyond that, and we ended up with a nice result with good flow into that obtuse marginal branch. So a fairly long case, but we were able to do it with a fairly minimal amount of contrast. Our radiation was a little higher than I like, but we were able to do this fairly safely. He was seen 6 weeks after this in clinic. I had talked to him about the fact that we still had another branch OM off of the Lima to LAD that we may need to come back for, but he was completely asymptomatic at this point, was seen by one of my colleagues. And it's actually an interesting gentleman. He travels in his RV across the country and works at different national monuments. And so he's actually not even in the area anymore. So, but we told him that if he needs any more work, he can come back. But one of the things that I wanted to talk and get the opinion of the panel on is, you can see here after we stented that obtuse marginal branch, there is some residual disease distal in the vessel. And you can see how the old vein graft has kind of tented up that obtuse marginal branch. And you know, I've become really gun shy about putting stents across old insertion points of bypass grafts, because you can see that there's a hinge point on that vessel. And some of the most frustrating CTO cases I've done are when I stent across and I get a beautiful result and they're back 6 months later with restenosis, and it's almost always because of stent fracture, because of that hinge point that's created by the old bypass. So I've gotten to the point where I try to just stent short of those hinge points and leave everything else. And if I need to, I obviously would if there was critical disease. But in a case like this where we have good flow, there may be some remodeling that occurs after you get antegrade flow reestablished in these vessels. And I try to avoid stenting across these hinge points. And I'm curious how other people are dealing with these types of anatomical complexities in post-CABG patients.
So Jason, I would just kind of agree with you. It's an underfilled vessel and just wait for remodeling. And I would probably just do gentle massage therapy for the distal vessel. And if he has symptoms, bring back in 3 months or even 6 to 8 weeks and take a second look and see if you have to do more work there. I wouldn't stent in the first go, at least.
Yeah. I think this is going to be a nice place in the future, maybe for drug-eluting balloons too. So.
Yeah, Jason, I agree with you. When you see the vessel kind of tented like this, I agree with you. I'm a little gun shy about stenting across those things, just because I worry about what's going to happen to the stent in the future. So, and you saw in my case, I stented just short of that graft, that I was using. So I think if they're straight shots and they're not very tented, I think it's fine to go across them. But you know, if they're tented like this and you can see them flexing, I think you're going to get a better outcome if you stent short.
Perfect. Well, again, I would like to thank everyone. Went a little over, but it was well worth it. Amazing cases. So again, thank you all for presenting those great cases. We'd like to thank all the people who attended. Just a reminder that you can go for CME and get CME for this webinar. And also finish by thanking our sponsors, Boston Scientific and Medtronic. So again, thank you all and see you in the next CVI webcast in a month. Have a great evening.